next speaker is going to be Dr. Thompson, and I'm curious to hear what to do when the right is really wrong.
Hello, everyone. My name is Iain Thompson. I am an internal medicine intern, actually, at the University of Florida, and I'd like to present to you today a case of what to do when right is really wrong, a case of isolated right heart failure in STEMI, and a discussion of some of the advanced therapies. So I have no disclosures. In terms of objectives, I'd like to discuss an interesting case that we had when I was on CCU. I'd like to provide a schema for organizing right heart failure, briefly touch on some of the pathophysiology associated with the right heart failure, and then discuss some advanced therapies. For a case presentation, we had a 67-year-old male presenting from an outside hospital to our tertiary referral center. He came in with substernal exertional chest pain, radiating down the arm to the back, and some nausea. He was given aspirin and atorvastatin en route to our hospital. When he arrived to us, his vital signs were within normal limits. His physical exam was notable for some mild anxiety, but overall he was doing quite well. So for the past medical history, he had hypertension, hyperlipidemia, and he was a pack-a-day smoker. For his laboratory values, when he came in, his troponins quickly elevated to above detectable limits. And on the EKG, you can see an inferior MI, ST depressions in 2-3 AVF, and then some reciprocal changes in the lateral leads. So for his coronary angiogram, all this brought him a trip to the cath lab, as you can imagine. And on the left side, you see some mild non-obstructive disease. In the middle, we see a proximal occlusion of the RCA. And on the far right, you see this is status post 2 drug-eluting stents in the proximal mid portion of the RCA. So he was loaded with ticagrelor, and he was sent to the CCU for further follow-up. So when he got back to the CCU, although his chest pain was greatly reduced, it never completely resolved. Later in the day, with the ongoing chest pain, we gave him some nitroglycerin, which unfortunately dropped his pressure significantly. We gave him intravenous fluids, but he never quite recovered. With the ongoing chest pain, we performed an EKG and saw ongoing ST elevations. This prompted another trip back to the cath lab. When we performed an angiogram, we saw an occlusion of the right coronary artery, as you can see here on the picture to the left. We performed mechanical thrombectomy with penumbra, and we put in another stent more proximal in the RCA, and this was the result on the far right. While he was in the lab, unfortunately, his pressures remained low. He began to have respiratory distress, and unfortunately was intubated as he was moving around on the table, and the respiratory distress ultimately led to intubation. We performed a right heart cath, and you can see the pressures on the screen here. He had increased pressures in the left side and the right side. He had decreased cardiac output and decreased cardiac index. Ultimately, we placed an intra-aortic balloon pump and stabilized him and sent him back to the CCU to be watched a little bit longer. While he was in the CCU, unfortunately, he developed complete heart block, which caused us to initiate pressors. He had an escape rhythm in the 30s. As that happened, gradually he recovered from that, and then unfortunately went into ventricular tachycardia, requiring a shock. While all this was going on, we had a multidisciplinary discussion as to what we should do, RP, Impella versus VA ECMO, and ultimately a decision was made to place him on VA ECMO. So to talk a little bit about our heart failure background, there's 4 buckets to consider for the right-sided heart failure. One is increased preload, increased afterload, decreased contractility, and a bucket of hemodynamic consequences that you can amalgamate together to make the 4 categories work. In our particular instance, decreased contractility was due to an RV infarction, which was the main reason that this heart failure occurred. So next, I've always taught to break things down into structure and function. So for the right ventricle is a thin-walled chamber. It pushes against extraordinarily low pressure system, being the pulmonary circuit. In terms of how this affects its function, it can accommodate very large increases in preload with very little pressure changes, and it's actually quite an efficient chamber. It's 1/5 the energy requirement for the left ventricle, and it is able to meet the same cardiac output demands, which is pretty impressive. For the LV, so some of the pathophys of right-sided heart failure, the main issue comes with right ventricular dilation. So as you know, the right ventricle dilates, it can obstruct the left ventricle, it can cause decreased filling pressures and decreased cardiac output, worsening heart failure, and additionally, the dilation of that right ventricle causes tricuspid regurgitation. This tricuspid regurgitation is the downstream consequences of a lot of the shock that we see, increased renal vascular congestion, all of the things that we see in the shock picture. For treatment, just briefly, increasing heart rate for these people is helpful as the increased heart rate decreases tricuspid regurgitation. In terms of rhythm, as we can see in our patient, these patients are extremely preload dependent. They do not tolerate changes from normal sinus rhythm. If your cardioversion early is an important consideration. In terms of in terms of contractility and blood pressure, starting inotropes and starting vasopressors is an important consideration, as was in our patient. Just briefly for RV afterload. So in pulmonary hypertension being the main cause of right-sided heart failure, you can consider inhaled vasodilators, epoprostenol, nitric oxide. Obviously, in the case of a myocardial infarction, this is a bad idea and not something that should be done. And then for RV preload, so when you have right ventricular failure with normal pulmonary vascular resistance, the preload is extremely helpful. And that's notable because in our case, we gave this gentleman with right-sided heart failure nitroglycerin for ongoing chest pain, and his pressures tanked and he never quite recovered. Next, I'd like to just briefly touch about some of the mechanical circulatory support options. So we have Impella, which is a right-sided specific percutaneous ventricular assist device. In terms of the pros and cons, for the cons, positioning can be challenging, as we heard in one of our previous talks. Hemolysis is an ongoing issue given the small pump size. And then the main benefit of it is that it maintains this anterograde flow, and you don't have the flow reversal as we will see in VA ECMO. So for VA ECMO, 4-component system, we have the inflow cannula, the pump, oxygenator, and the outflow cannula. Some of the pros and cons. Essentially, it's the last line of defense before you move into the left ventricular assist devices. It oxygenates the blood, which in the setting of the days of COVID can be helpful. Unfortunately, it requires LV venting strategies. And in our case, the intra-aortic balloon pump that we placed was that strategy. And some of the other consequences are north-south syndrome as well as acute limb ischemia. So just for some final thoughts to wrap up here, I asked myself the question as an intern in internal medicine, what can I provide to a shock conference? And I think I came to the conclusion that the answer is a reminder that ECMO is a bridge. It's a bridge to transplant. It's a bridge to recovery, to a durable mechanical circulatory support, or time for a frank and honest conversation with the family in terms of what the next steps are. In our case, our patient actually had recovery of biventricular function and actually walked out of the hospital just a month later. So in our case, it was a bridge to recovery. Here are my references, and I just want to say thank you so much for the opportunity to speak. It's been fantastic.
Very good. Thank you very much. Any comments, questions?
Yeah, a great presentation, great outcome. A couple of observations that you highlighted. Obviously, inferior infarct patient at risk for RV infarction. You didn't show us an EKG that showed right-sided leads, and for the folks out there, it's easy to forget in the middle of all that. We have to look at that to give us that clue. Easiest thing to do is, by the way, is look at the neck veins. Neck veins are up. They're having an RV infarct. It's little things like that we don't remember. I think the other thing that's important that you illustrate is that RV infarcts, particularly revascularized RV infarcts, get better. They get better in a few days as long as you support them for that. It's not like as serious in terms of LV infarction. So, being on top of that early and supporting was great. You had a great outcome.
I think you did terrifically well. You can apply for cardiology. I'm a cardiology program director. You're on the right track right now. So that's good. I think two things to emphasize in your thing was, one is the importance of maintaining AV synchrony. So when you go into complete heart block, just putting an RV pacing wire is not going to get you there. You want to get AV synchrony on that. And the other thing is, volume is not always your friend. So when you put this guy in and you put that wedge pressure and you see the wedge pressure is 30, it's not necessarily, like you said, that it's a left-sided issue. That interventricular septum has already gone so far into underfilling your left ventricle that all you're giving is more fluid and getting worse and worse. So you need to somehow bypass that right ventricle. And whether in the old days it's dobutamine or here it's an RP Impella or something, you need to do that. But like you said, time is your friend. You should never, ever give up on a case like this, because if you can get them through those next 24 to 48 hours, the future is bright. So you got to hang in there with any kind of support you can.
And the other thing I was going to add is The wedge of 30 is really an outrageous wedge for an RV infarct, telling you the delay and or inability to be able to get that RV back even though the RCA was opened up. I mean, it looks like probably the reocclusion happened quite quickly. Initially, the heart rate was slow. I did see that EKG with that slow heart rate. I was just thinking, the pacemaker, is it already there? Was that flow really stagnant, even post-PCI? Did this individual need a little bit of a higher flow? Just opening the vessel was not adequate to achieve that kind of a healthy milieu to be able to keep that stent patent over there. Whether there also the heart rate played a role in that, reocclusion. And keep in mind that LAD, I didn't see the late filling on the coronary arteriography. I didn't see the apex from the LAD. Why was that LV maybe struggling? So was there a concomitant reason for the biventricular failure, or was this solely a very delayed, non-perfused, timely, RV infarct? Those all come into question, but of course this can definitely happen with a bad, RCA, proximal, typical RV infarct, but you guys did a good job.
And the pacing comment is really important because this is not somebody you'll set a pacer at 60. I mean, you'll atrially pace, AV synchronously, but you want it at 80. I mean, it may 80 or 90 may be what you need.
Or you want to see everything,
Right.
going back to sort of a normality after you do the PCI. Things usually improve after that, but if things look funny after the PCI, heart rate is not improved, and everything is in a still heart rate of 50s. There's something wrong there.
Yeah. Drop in a central pacer
Quick,
seems like
quick,
the
quick
combination.
Thank you. And great case. Just I want to underline again the wedge pressure was high, which is, I think you already mentioned that, give you the magnitude of the problem you had in the cath lab. Why you didn't put a mechanical circulatory support in the cath lab? The guy was having high CVP, high wedge pressure, cardiac index is low. Would that discussed at that time? And he's in shock.
Yeah, I think the goal for the intra-aortic balloon pump was to try to offload the LV. We suspected that some of the like I presented with the RV distension causing decreased LV pressure. We thought that maybe if we could offload the LV a little bit, we could help improve a little cardiac output. But to be honest, the patient was extraordinarily anxious, moving around on the table, and it was a bridge to having a discussion about placement of ECMO. It was a short-term strategy for stabilization to get him back to the CCU to move on.
Just one comment, because I think twice we talked about the wedge. One possibility, and this I have to credit Dr. Chatterjee who taught me this, if the RV distends a lot, that's what's called the reverse Bernheim effect. You have end-diastolic equalization, so the wedge, the RA were close, and the PA diastolic. That's just, if you would have had an echo to show us that that's a pancake LV, there's no way that intramyocardial pressure cannot be 30. That's a pericardial to myocardial transmission. Right. And, but I want to tell you, as an intern, Bindu said this, I wish you could have been at Parkland, because I was just so proud to see an intern present like that. I haven't seen an intern present like that in many years.
Absolutely.
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 I think you raised the standard for AVIF.
Thank you so much. I really appreciate it.